We listened to 5 beautiful lectures, and this is open to live discussion. We have 6 panels: 국형돈, 신상훈, and 승재호, 유재석, 이상록, 정우백. Please feel free to raise questions or comment. I'd like to ask Dr. De Beer. So, can you compare the success rate of Basilica in surgical failed valve versus native bicuspid valve, or the TAVI valve? Is the same success rate?
So we do not have a great comparison. It's only my gut feeling that I will describe. Obviously, it's a bit different. The challenge with native valves is the fact that they are always heavily calcified, almost always. These are AS patients, right? In failed bioprosthetic valves, these are sometimes very gentle leaflets. Sometimes they failed from aortic regurgitation, not because of stenosis. So it's easier sometimes to traverse failed bioprosthetic valves in general when you sit correctly behind the leaflet. However, when you have native tissue and not a bioprosthetic valve, there is not a lot of material in the aortic root that you need not to be entangled with. So this is the benefit of doing TAVI in native valves. So there are no surgical valve posts, there is no ring that you need to avoid and not to go behind it. In general, it depends what anatomy you have when you compare these two, bioprosthetic valves and native tissue. For aortic root tricuspidization, for bicuspids, not at risk for coronary obstruction, we do not have enough data to suggest whether the procedures are different than native cases coming for prevention of coronary obstruction. But the cases that performed to date in my practice were quite good.
Thank you. So in terms of shortcut device, so I showed the very good flashing system in approaching device to the leaflet, but many TAVI patient has very tortuous aorta. So I I suspect in some patient the flashing system cannot work. What do you think about that?
The first patient that came for a shortcut procedure was a patient with extremely tortuous aorta, with a post-bental kink in the narrowing in the ascending aorta, that I actually thought that Basilica would be very complex and challenging. And that was the first in human case of a shortcut device. Until now, we did not fail with shortcut positioning, also in complex anatomies. It could be, and there are more than 50 cases to date. It could be that eventually we'll have very challenging anatomies. So surprisingly, I can say that the device works also in complex anatomies.
I have one question to Won-Gun Kim. We are discussing about the valve in valve, and we also discussed the sapien in evolute in sapien. But about after listening your lecture, it looks like accurate neo 2 is best for the valve in valve system. How do you think about the outcome of the valve in valve about the accurate neo 2?
Yeah, there was not much time to go deeper into the data, but I think at least it's of course not a randomized comparison, but I think it's a relatively large number, and we show that it's feasible, first of all, and that you can achieve at least similar outcomes. In some aspects, I think there might be advantages using the accurate. We know that the Evolute, we have to acknowledge that it's best in class for hemodynamics, but even the accurate Neo seems to be similar for valve-in-valve. And I think there's a big advantage of the accurate Neo in terms of coronary re-access. And we know that for coronary access, the Evolute is worst in class, and the accurate is, of course, not as easy as the Sapien, but I think much easier, especially if you have commercial alignment, than the supraannular valve. And just last week, I've treated one patient with degenerated accurate in bioprosthetic valve, and this patient had AR, and I was able to insert a second valve, a Sapien. So without having any concern of coronary obstruction or coronary access. So I think this is a combination that you might take into consideration in your armamentarium.
I'd like to ask Andre Pap. So, after listening to your lecture, I think of super overhanging is very frequent in Sapien in Evolute. So, in cases anticipating overhanging, considering it's better to consider Evolute in Evolute, or any advantage of Sapien in Evolute in cases anticipating overhanging?
Well, I think the reason that, ideally we would never have overhang. Ideally we would implant the Sapien high enough that you pin up the leaflets and the coronaries are okay. But the reason that we do the overhang, we allow overhang, is to avoid coronary obstruction. So it's not something that we voluntarily do. It's something that we were kind of forced to do. And I think that it's something that always makes me nervous because we have no data on the long-term effects of leaflet overhang, whether it's associated with a risk of sinus thrombosis, where it's associated with reduced durability. It's going to take years for us to get that information. I think also that you have to take into account when you're thinking about leaflet overhang, how the valve failed. If the valve failed by aortic stenosis and it's heavily calcified, then most likely the leaflets are going to be rigid and you're going to be able to push them away, and they're not going to have as much of an impact on the new valve. If the leaflets are soft and it's mainly failure by aortic insufficiency, then I think leaflet overhang is more problematic, and you have to think about the long-term implications.
Thank you. Any more questions?
So I have one question for Dr. Yin. So you have nicely demonstrated that these younger patients will be benefit from the larger effective orifice area. So this patient will be suitable with the supraannular designed valve. But ironically, the valve-in-valve procedure, you demonstrated that the self-expandable valve in balloon expandable valve will be the best strategy. So this ironic situation, so what would you choose to the first valve in younger patients in these scenarios?
Well, it depends on the artery anatomy. If the anatomy is big enough, I think no matter which one would be better, would be okay. If it's a small annulus, I think supraannular valve will be a better option. And if the coronary is an issue, I would take balloon expandable as the first valve. That's my usual practice.
Okay, thank
Actually,
you.
in patient already have a Sapien. Many physicians or many doctors put a second valve-in-valve as using another Sapien. I want to show that there may be problematic regarding the hemodynamics in the long run.
Yeah, we listened to 5 excellent lectures and there was a lively discussion, and it's time to close the session. Thank you for all the speakers, and especially Dr. In, Dr. Dibio, Dr. Kim. Yeah, it's night. I think it's just afternoon, but I think you are in the midnight. So thank you for your contribution to this symposium. So we'll see all of you next time. So thank you.